Very, very warm welcome to you on this chilly grey day. We've got a really interesting webinar today, haven't we? How can a GP help people with young onset dementia? And in a moment, Dr Nerida Burnie, who's a practicing GP and runs a community dementia clinic, will be telling us all about that. But first off, we're going to, as we always do, we're going to start with some conversation between Catherine and Martina Davis, who lives with young onset dementia, and she's going to talk to us about her experience of with her GP, really, the GP relationship. Don't forget that although you're not on camera and mic, we very much encourage you to use the chat. But also to put your questions, please, in using the Q&A function. Okay, thank you, Catherine.
I'm delighted to be joined here by Martina Davis, who was diagnosed with posterior cortical atrophy after she noticed symptoms starting in her mid-50s. Thank you, Martina, for being here today to share your experience and your thoughts with us. So during this webinar, Dr. Burnie will talk about how a good relationship with your GP and your GP practice is key to supporting a person with young onset dementia. Please, can you tell us a bit about your experience you had with your own GP when you first started to notice symptoms?
Now, I was very fortunate with my GP. It was when I lost the numerical skills, I actually went to see her and I said, there's something not right. I know there isn't. I know I'm not functioning in the same way. And I got a good measuring stick for this because I've been self-employed pretty much all my life. So, you know, chief cook and bottle washer, sales, admin, tea girl, getting the business in, delivering the service. So I actually measured it and I knew there was something wrong. And my last business was a gallery that I'd set up for local artists because I'd had a lucky break and I wanted to pass that on. So when I was at the GP's and she was talking to me, she actually said, Martina, I've lived through Daffodil Lane and the setting up of the gallery. She said, if you're sitting here telling me there's something wrong, there is something wrong and we need to get to the bottom of it. So I consider that I was very fortunate. And I know I'm fortunate because most of the stories are horror stories about the GPs. And she got an inkling, I think, that it wasn't Alzheimer's, it wasn't going to be particularly memory-led, but she wasn't in a position to do it. She had to do the memory tests, which is what she went ahead and did. So I consider my experiences when I first started to notice my symptoms, my GP sat up and listened.
That's so important that you had that relationship with your GP to be able to be open and honest, and she recognised that there was something not right and that needed to be investigated for you. And then after you received your diagnosis, what ongoing support have they provided to you and how has that helped you?
They have actually just been fantastic, and between two lady GPs, they handled me beautifully, let me put it that way, in terms of they got really good coordination, or communication rather. That communication between them was absolutely brilliant. And I can remember being asked by one of them, this was during COVID, when you could actually go, you still could go to a GP's. When everybody else was pushing for telephone calls, they made a decision to give me the option of actually, and it didn't matter what it was, I could go and have a face-to-face. And that was so incredibly important. And it was such a tiny thing, but it made the biggest difference to me because PCA also affects hearing, but not in the same way as if you're losing your hearing. Now, since then, I am now wired for sound. I do need hearing aids, but I experience the difference in the messages within my brain for hearing. So they had taken that on board and knew that telephone calls weren't so great. And it's always been, and ever since, it's always been a face-to-face. And please don't ever hesitate to have your double appointment, you know. So I mean, that's just one tiny example of the ongoing support that they actually give me.
That's really good. And how important is it to have that support from your GP while you're going through this, the pre-diagnosis, through the diagnosis, and then ongoing?
It's actually invaluable. There's no other word to describe it, because you've got somebody that you can actually communicate with, that understands. And like a lot of the rare dementias, a lot of the GPs don't know anything about them, and you know, the clues in the word, the general practitioners. But my practice have been prepared to learn, I think. And this actually is cascaded down even to the receptionists that are on the desks. You know, they care very much about the patients that come through their door. Yeah.
So what improvements would you like to see in terms of how primary care support people with a diagnosis of young onset dementia and their families?
I would just love to see repeated across the country my experiences with the GP service, primary care services. It's really, really tough, and I think one of the biggest humps, I can't think of the word, but one of the biggest humps that needs to be overcome is this automatic assumption that all dementias are memory led. I mean, even Alzheimer's, younger people that are having symptoms, they're not necessarily memory led at that point because of the age.
Yeah.
And so if you're failing those memory tests, and you're either being told, oh, come back in 6 months, or there's nothing we can do for you, there's nothing wrong, it must be stress or it must be anxiety. I find it absolutely ludicrous that the diagnosis, the diagnostic period is still so long. And yet there was all this cracking talk about this drug, which, oh, if it can get to people young enough, it's going to help. But if the diagnosis period is that long, all those people have missed out.
Yeah, it's not going to help. Well, thank you very much, Martina, for sharing your experience with us. It's really lovely to hear what a positive experience you've had with your GP and continue to have with your GP. You've had consistent support from them. And I think that's really something that you've said to us a lot, that how important that is in your life. So it's really good to be able to share that with people today. So thank you very much.
No, thank you, Catherine.
Thank you.
Hi, many thanks to Martina and Catherine for that conversation. It's so good, isn't it, to hear positive experience and to know how valuable the support is right from the beginning, and you know, to have that continuity throughout. I just want to say that there's a fuller length conversation that's going to be available to you on the follow-up email. So we'll make sure that you've got a link to that. So that's Martina and Catherine full length video. I'm going to hand over to Nerida now, who's going to introduce what the GP can do for people with young onset dementia, and she's going to talk us through various aspects of that. So very much looking forward to this. Thank you, Nerida.
Thank you, Tessa. So hopefully you can now see my slides. So thank you very much for the invitation to speak today. And thank you, Martina, for that really great introduction to the whole topic of GPs and how they can help people with young onset dementia. Just a brief introduction. I am a GP. I work in Southwest London as a GP, but I'm also a GP with a special interest in dementia. And as Tessa's mentioned, I run a community dementia support and follow-up service for people in our local area. I've also got some strategic roles working within our local ICB and also with the London Dementia Clinical Network. So I hope I can bring to this talk not just my experience and perspective as an individual GP, but also a little bit as a strategic level, thinking about how we can share good practice and how we can recognize when things aren't working well and see what we can put into practice to improve things for everybody. So yes, today I want to talk about some of the different things that a GP can do to help support people who have been diagnosed with young onset dementia. I thought I'd start with just reflecting on GPs within the NHS. I know not all of you on this call today are from the UK, but the role of a GP in the NHS is a little unusual compared to other countries. In the NHS, we have a set registered population of patients. So patients register with a GP practice, and that is their point of care for all access to NHS services effectively. It's often the gateway to accessing many different services involve you needing to go through your GP. The GP also holds all the NHS records for that patient, not hospital notes, but they have usually a lifelong history of the person and their health issues, which is quite a unique situation that I don't think we reflect on and recognize enough. We carry out investigations, we do initiate referrals, we review and prescribe medications. There's lots of roles that we take on, but I would say we are one of the few remaining generalists within healthcare. So by that, I mean, in most hospital settings or in a lot of community settings, you might be seeing a specialist for your heart or a specialist about your lungs. But other than maybe the geriatricians, GPs are one of the few remaining true generalists in healthcare. And so we're in a unique position to take into account the whole person and think about providing holistic care. We don't discharge patients from our service. Someone's always going to be registered with a GP. And so one of our key roles is very much around provision of long-term condition care. And obviously, dementia and young onset dementia is just that. It's a progressive neurological condition. And so providing long-term care and follow-up for a condition is very much something that I think falls within the GP's remit. And I would certainly say, because dementia is a progressive long-term condition, continuity of care is so important. We've known this anecdotally for years. We've all known that if we're seeing a GP who knows us, and as a GP, if I'm seeing a patient and I know a lot about them, I know it's easier for me to provide good care for them. But this recent study back in 2022 proved it. It showed that patients with dementia who see the same GP have a better quality of life. Now, I know this wasn't specifically about young onset dementia, but I think we know that it's going to hold true as well for people with young onset dementia, that continuity of care also will improve the quality of life and the quality of care provided to somebody with dementia. But, and here's the big but, providing continuity of care in a stretched system which is short on resources is really challenging. And unfortunately, I think this is what's the key thing behind a lot of the challenges that we hear from people receiving good care from their GP in England. So this is a really stark reminder of what's changed in the last 10 years or so. So in September 2015, we had in England 29,364 full-time equivalent GPs. By July 2024, we have 1,702 fewer full-time equivalent GPs. So we're down to 27,662. So as we've always said before, we have a registered population at our GP surgery, So the average number of patients per GP, full-time equivalent GP in England, back in September 2015 was 1,938. Now we have 355 more patients on average, an 18% increase. So I think these numbers do give us a pretty stark picture of where the challenges are in general practice in 2024. So when those of you who are patients in the UK say that they think it has been difficult to get an appointment with a GP, or when they get a GP appointment, the continuity has been difficult to achieve, this is why. So you're not imagining it, it's true. So we can't necessarily change that, but we need to think about how we can work differently and we can work smarter to try and still provide the optimum care for people. Young onset dementia, as Martina so beautifully put it earlier, is such a specialist condition. In many ways, it's such a specialist condition. There's rare types of dementia, often unusual presentations, often challenging symptoms, are all part of what we know makes up young onset dementia. So often specialist care and specialist centres may be involved in parts of the care of someone with young onset dementia. But I still maintain that there are some key things that a GP can do and should do to support somebody with young onset dementia. I've listed some of them here today, and I'm going to go through a few of them in turn. But certainly I think it's important to consider what a GP can do about helping a patient get a diagnosis. And then after the diagnosis is made, they have a role in things like annual review, discussing work, discussing driving, health matters like comorbidities, polypharmacy, advanced care planning, and of course, the impact that the young onset dementia has on the family members and unpaid carers involved with their care. So that's a bit of the structure of the sort of things I want to go through today. So first up, the big debate about why is it so hard for someone to get a diagnosis of young onset dementia. And I fully agree with Martina, that average time of 4 years is just too long. And I think the main pushback I often think we get, particularly as GPs, we are that first point of contact most often. Why is it so hard that the average time to diagnosis can be, 4 years? Firstly, I think we should think about what are the variety of conditions that a person may be presenting with if it's not young onset dementia. And I've put a few of them here. I'm sure you've got a few of that you could list and add on as well, of maybe what your experience tells us you were told initially or your family member was told initially was the problem. Anxiety, depression, stress, menopause. All of these conditions have certain symptoms which could also indicate a problem with something like young onset dementia. So those early symptoms in young onset dementia could well mirror some of these conditions. But people will often say, why didn't my GP think about young onset dementia when I presented with these symptoms? Why didn't they think about it and refer me on to the right place? Now, I don't pretend to have all the answers for that, but I'm going to talk you through an illustration of one of the reasons I think behind what could be behind it. Horses and zebras. So I clearly recall in my medical training as a student and then in my early years of practice that we would learn about lots of rare conditions with really fascinating symptoms. And it was great. You get so excited about hearing about something new and something different and really interesting things. And then when we'd be seeing patients on the ward as a student, our tutor might ask, so what do you think's going on here? And we come out with all of these great list of things that it could be. And I think our tutors would remind us to say, common things happen commonly, rare things happen rarely. So if we saw a patient and we suggested something that was slightly rarer, they'd go, do you think that's really likely, or is something else more likely? So if we think about the fact that a GP will see maybe 10 people a day with symptoms of severe stress and anxiety, which are presenting with some symptoms which could potentially be young onset dementia, I think we'd all be thinking about the more common things. That's not to say that the rare things don't exist, but it might not be what we first think of, or what we think of as being most likely. So why horses and zebras? If we hear hoofs, the sound of hoofs galloping along, is it going to be a horse or is it going to be a zebra? And that's, I think, the main trap that we as GPs fall into. And how do we change that? We need to remind people that zebras exist. We need to remind people and raise the awareness in the public and also within GPs about young onset dementia. It does exist, it can happen, and whilst it's not common, it's really important that we try and identify it early on. And I think this is the big challenge that we need to take on as a system to make sure that staff are all aware of the possibilities of things like young onset dementia. But also, I think as an individual person, you know, we need to say, if we have a suspicion that it's something else, we need to keep reminding the GP of that and say it, put a name to it and say, I'm worried this could be young onset dementia. Is that possible? And I think that will help remind people that zebras do exist. They're different to horses and they do need different care. And rare things do happen. How rare, how likely is a GP to come across a person with young onset dementia? If we look at the numbers, it's hard to say for sure, but we're probably looking at each full-time equivalent GP having 1 or 2 people with young onset dementia within their caseload, which is obviously nowhere near as common as many other illnesses and conditions which may cause similar symptoms. So enough about my horses and zebras. But I think, what else can we do to try and see if we can improve the likelihood of a GP thinking about and making that diagnosis of young onset dementia within a timely manner? I really commend this guide to you. I know probably a lot of you on the call are aware of it, but it's certainly something that I think we need to make sure is shared and promoted. And I commend anybody working in primary care as a clinician to use it. It's a really good tool just to help you think through, could this be young onset dementia? Yes, of course, there are things that you need to assess and exclude first, investigations to check and see whether there is a reversible cause of the symptoms or another explanation, which is more common cause of the symptoms that people are presenting with. But this guide does help you think through that challenge. Experienced GPs particularly, do have gut reaction when they think it doesn't sound quite right. And that's when we need to be listening to that gut reaction and thinking, all right, could it be that it's young onset dementia I'm looking at? The links to these guides will be shared with you afterwards, so we'll be able to let you know about them. But I think the other part of the equation then is not just recognizing this could be young onset dementia, but then it's about saying, so what do I do now? And local pathways are very different in different areas of just how someone can go about getting a diagnosis of young onset dementia. It might be through the neurology pathway, it might be through a memory clinic if they have an all-age service, but definitely get to know your local pathways once you've identified the possibility of a patient having possible young onset dementia. So after the diagnosis is made, what else is the GP's role? As well as identifying the possible young onset dementia and making the appropriate referrals, what else are we able to really get involved and support a person with? These are probably the key things I've thought of, and I'm going to sort of in turn go through each of them a little bit. But an annual dementia review, support and advice for the person around work, support and advice for the person around driving, managing comorbidities and other health conditions that the person might have, avoiding or addressing inappropriate polypharmacy. So if the person's on multiple medications, are they all still needed? And supporting family members, including young carers, and advanced care planning. We know that it can be difficult to get appointments with GPs. We've already gone through the numbers of maybe why that might be. But here's some of the top tips that I would suggest we take away. And if you're a patient or a carer on this call, or if you're on the other side of the desk and you're the clinician, just think about how we can support to make sure that these things could be possible. Ask for a double appointment if it's at all possible. Take a long written list of the ideas and the things you want to talk about, and definitely come up with the most important question first. If it can't all get covered in the first appointment, okay, see if you can rebook with the same GP for the next appointment. Take someone with you. 2 people remember the details so much better than 1 person on their own. And so it's really helpful to take someone along to support when you've got lots of questions that you want to ask. Try and have that continuity with the same GP. It's not easy, I know, but it's beneficial on both sides of the table. Most GP practices will have a clinical lead for dementia. So one of the GPs will be nominated as the clinical lead, or perhaps if they don't specifically have a dementia lead, they will very likely have a mental health lead. See if you can ask to see them, because it's likely that they may well be the person who's best placed to try and help. And obviously from the GP side of things, if you can, make that follow-up appointment yourself, because then you know what time you need with the person the next time around. But I would also say, find the right GP. Now, if you live in an urban area, it's very likely you'll be in a catchment area for more than 1 GP practice. So if it's not working for you at the GP practice and you're with, maybe have a think about whether you look around and see if there's a practice in the where you're able to change your registration so that you have another option of where you might be able to be seen. So I don't just mean the individual GP at the practice, I also mean the practice itself. Does it have the right location for you? How do they go about booking appointments for patients? Does it suit you in that way? The best care will definitely come from a good relationship between a GP and a patient, and also a good relationship usually leads to mutual trust. And I would say that's true of any condition, but it's especially true of something like young onset dementia. So GPs definitely have a big role in providing an appropriate dementia annual review. So GPs in England have QOF, a quality program, where basically there are certain things that they need to do to show that they are providing good quality care. And one of those is that anybody in their practice with a diagnosis of dementia should be having an annual review. Now, we know that this looks different in different practices, and some practices and GPs are much better at doing this than others. And it may well be that it's more appropriate that it's done by someone who knows you well outside of the GP practice. But the GP is certainly, it should be providing a good annual review for you. And the better somebody knows you in the continuity of care, the better they know how they can support you on your journey. And care planning, we've got a good care planning guide from NHS England, which we'll also share with you after, that goes into more detail. But it should be things about what's changed, what's important, those sorts of things need to be considered when we're talking about an annual review. This is, I think, what I would say are the key things that I think need to be covered in an annual review. We should definitely be looking at what changes in cognition have occurred since the last annual review. We want to find out about new symptoms early. We want to look at the physical health of the person. Has anything changed? We want to look at the mental health of the person. Have they got a mood disorder? Has they developed depression or anxiety? I think it's good to touch base and find out what social care involvement they have, what sort of care package they might need at the moment. Is it adequate? Should we be making signposting? Should we be signposting for it to maybe be reviewed? What sort of social activities is the person involved in? Are there things we could do to help them see the benefit of continuing to go to the golf club or do whatever they used to really enjoy? We should be reviewing their medication. Work issues. Is it that information is needed for the occupational health at their job? Is it that they need certificates for work to say that they need some amended duties or alterations to their duties? Is it that they need a certificate so that they're still able to access benefits, job seekers allowance, those sorts of things? It's really important that we look at the care as well. And by that, I mean the unpaid carers, the family members, making sure that their health and well-being is taken into account, and see if there's anything we can help signpost them towards. Advanced care planning, I think, should always be part of a dementia annual review, and we'll go into that in a little bit more detail later on as well. But as with anything, I really think that an annual review needs to be personal. It needs to be personal for the person and cover what's really important to them. Make it personal, make it count. Driving with young onset dementia. We all know how important driving can be for people. It can be a really important part of our independence that we can use a car and drive. It's an overlearned skill, and some people with cognitive impairment will be able to continue driving quite safely for a period of time. Whereas others, if their judgment's impaired or if they've got spatial awareness difficulties as part of their dementia, it may impact their driving very early on. So doctors can certainly find themselves in a difficult position of trying to encourage a patient to think about retiring from driving. And I think that balance between mutual trust between doctor and patient, and also taking into account public safety of someone driving when we don't think they're safe, can be quite tricky. And so another resource I would commend for you, and the link, as I say, will be sent to you, is this consensus statement, which does go through the different steps and responsibilities each of us have in different scenarios of working with the DVLA. And we know that as a GP, we can regularly be asked for information from the DVLA and filling in paperwork and forms. So it's yet another place where the GP has a role in helping people with young onset dementia. Comorbidities and young onset dementia. It's quite possible that the dementia is not the only health condition that a patient has. And so we need to think about, what does having young onset dementia mean when we as GPs are trying to provide care for health issues for people? So by that, I mean, if somebody has asthma and they've always managed it quite well, but after developing young onset dementia, they have a bit more of a challenge around coordinating the technique of how to take their inhaler, for example, then we need to think about that and recognize that there could need to be some changes in how we treat the asthma because of the young onset dementia. Conversely, if someone doesn't have their diabetes well controlled, it may impact their cognitive levels of the young onset dementia. So I guess this comes back to the point that I was saying at the start. GPs are one of the few true generalists that still are part of the healthcare system. And so we sit in a unique point where we can help try and translate or reconcile the treatment of other physical health conditions with the treatment of the person's young onset dementia as well. And so taking that holistic overview of all of the parts of the person's health is quite an important thing that a GP is able to help with. Some top tips around polypharmacy. It's straight, it might sound fairly simplistic, but it is true that if you can look at the medication regime for a person, think about how it fits in with the lifestyle of that person and the care package or the family routines. Maybe it's about making sure everything's just in the morning. Maybe it's about trying to make things once a day as much as possible. Having a think about how the medications you're prescribing fit into the lifestyle of the person with young onset dementia and trying to make it as easy as possible. Specifically, some medications have what we call a high anticholinergic burden, and so it can impact more on their cognition levels if they're on a number of those medications. There are some tools available when you're doing a medication review that you could have a think about, are there changes here that we might need to make? Antipsychotics are a particular class of drug that are sometimes used in young onset dementia. They can be really important and helpful for managing some challenging and difficult symptoms, but they come with a risk as well. So having those individual conversations with the patient and the family around the risk benefits of certain medications is really important. I would say symptom management in young onset dementia can be very tricky, and I think it certainly needs a specialist involvement for a lot of situations. But being able to fit that advice in with the bigger picture of their other medications will certainly likely involve communication between the GP and the specialist. So the impact of young onset dementia on the family, and how can the GP help in that circumstance? I think certainly we recognize that one of the key differences between young onset dementia and dementia that comes on later in life is around the age of the family members involved. So things like young carers having school issues and exams and those sorts of things, having continuity of care, knowing the family that the person comes from, and being in a position to try and support and help as much as you can is really invaluable. So it might be about just listening, and it might just be about understanding, but it could also be that you're signposting for various supports available for young carers, or perhaps for support with exams and things like that. The implication of possible genetic inheritance of young onset dementia, and the question around genetic testing, whilst I certainly don't suggest that that's a GP topic, but I think understanding and knowing that that is the case, that this could be a significant issue, means that you can help, I guess, translate advice that might come from a genetic clinic or from a specialist clinic, but just an awareness in general of the impact on the family of genetic testing and what that might mean to the family. So a good relationship with a GP would mean listening and support for all of the family members involved. Advanced care planning. I think this is something that we all should be considering and thinking about. What's important to us? What matters to me? But these conversations are even more important with someone with young onset dementia, while their capacity is intact, while their communication and ability to communicate is intact and easier. That's when we want to be having the conversations and asking them what's important to them, what matters to them, what are their wishes. And so it's about asking and listening, but it's also about recording those wishes. And where those wishes are recorded and how they're recorded is equally important. So in London, we have a universal care plan, which is a digital care record that's accessible. In other areas, it might be about a respect form. I think just the main issue is have the conversations early about what's important to the person with young onset dementia, and have it recorded what their wishes are. I don't think any of us are good at starting these conversations. And certainly as a GP, we're perhaps not the best, but we need to be better at it. But I've never yet found that patients don't want to talk about it. Patients want to talk about their end of life care. Patients want to tell us what's important to them. But if we don't open the conversation, we're not going to hear their wishes, and we're not going to know what would be their requests. Like me, I'm sure there's a number of you who work as GPs who do have a role in local service planning. And I would really urge you to use that influence to advocate for change. Speak up and advocate for your patients if you recognise there's a gap in care or if there's a gap in service provision. Ask the question, talk to the people who have the funds. Not that anyone's got any money left in the NHS at the moment, but we need to be pushing and asking and advocating on behalf of our GPs, on behalf of our patients, and particularly patients with such a complex and challenging condition like young onset dementia. If you work in primary care and you don't have a role in clinical lead, that's fine. There's still things you can do to help as well. GP coding is so important. It is the source of NHS data. They look at GP care records to look at numbers, incidents, issues. So the better and the clearer you code, the better the information or the validity of the information that the NHS holds. So code the dementia subtype clearly and correctly. Code the ethnicity of the patient. Code whether the patient has a carer or if they are a carer. Ask about carer contingency and make that record somewhere. We need to support our patients to find the appropriate gaps. When there's service provision gaps, we need to help our patients find the answers. So in summary, I've gone through quite a lot of information today about how I feel a GP can help people with young onset dementia. I suspect there's other things you would add to that list as well. But we need to recognize that there's a lot that the GP can do to support and make things easier for a person with young onset dementia. But there's reduced resources. So we do need to recognize that it is a challenging climate in the NHS at the moment. We can't work any harder. So we all need to work out how we can work smarter to see if we can make things better going forward. So thank you so much again for inviting me to speak today. I hope it's been helpful and given you some information to think about. And I'm very happy to take any questions.
Thank you so much, Nerida. That was such a clear walkthrough of everything that GPs can do to support people with young onset dementia. You covered such a range of different aspects, didn't you? That was excellent. Thank you so much. If you stop screen share now, yes, and I will dive into the Q&A, and I'll just go from the top, if you don't mind. So first question, can bipolar diagnosis be in fact young onset dementia?
Oh, I think that's quite an interesting question, isn't it? I think certainly in the early phases of young onset dementia, there would be crossover of symptoms. So it's an interesting thing to keep in the back of the mind for diagnosis. It is the sort of thing that with time, we'd work out which it was. So if the person has had bipolar symptoms over a period of time, and they really haven't progressed, it's very unlikely that we're talking about a young onset dementia, because we know it is a progressive condition. But it's a question to ask, and I think it's a reasonable one to think that there could be crossover with various mental health illnesses.
Thank you for that. Do you consider social prescribing following diagnosis?
I think that's a really good topic. For those who aren't from the UK, we have a system of social prescribing that most GP practices will have social prescribers in their PCN, their primary care network. Social prescribers are really good at helping people find solutions and answers to problems that they've come across. Lots of people tell us they don't like just to be signposted and told about something. They would quite like support to try different activities or find different answers. And that's how a social prescriber would certainly be able to help. Just to walk alongside a person with young onset dementia while they were trying to find activities and resources that might help them. So yes, I think there's definitely a role for social prescribers in helping people with young onset dementia in the community.
Thank you. You mentioned during your presentation that a GP may have a couple of people with a young onset dementia on their caseload. How does that compare with those diagnosed over 65, so sort of later onset?
Oh, that's a really good question. So if I think about my caseload, so we would probably have something like more like 100 patients with dementia. Again, really varies depending on the age group of your population. Our practice looks after a care home, so we probably have a slightly higher number of patients with dementia over 65. But yes, that's the sort of proportion we're probably talking about, 2 as opposed to 100.
That's a very significant difference, isn't it?
Mm-hmm.
My experience, I don't know what DWP is. Do you, Nerida?
Department of Work and Pensions.
Okay, thank you. So, apologies for my ignorance there. So my experience with Department of Work and Pensions is that calling Alzheimer's a mental health condition is unhelpful and leads non-professionals to make the wrong assumptions. Do you agree? What are your thoughts on that?
It's not something I've got a huge amount of experience with, I have to say. I think certainly when we're asked to fill in paperwork and forms for things like benefits and pensions, I think you have to be incredibly specific. And I think it can be certainly a challenge if someone with young onset dementia has not yet been able to get a specific diagnosis, but clearly they've got impediments that are getting in the way of their ability to work. Yeah, it's a tricky one, isn't it? Dementia has often been talked about as or sort of sits under the umbrella of mental health, but it's not purely a mental health issue. There's clearly also, a physical condition as well as a mental health condition. So I think usually I try and be as specific as possible with any feedback to organizations like DWP. It's not just about hopefully you can give them a diagnosis, but you also can usually include what impairments come along with that diagnosis, just to try and be as specific as you can as to the person's ability to be able to continue working, for example.
Yes, thank you. That's very helpful. In my opinion, every GP practice needs a Nerida, but the question is, does every GP practice or primary care network have a dementia specialist at least, like you?
I would really like to hope that each GP surgery and certainly each primary care network should have someone who wants to take the clinical lead for dementia in that area. It could be an allied health professional. you know, I don't think it does always have to be a GP. You know, we've got some amazing nurse practitioners or other people who've got a real interest. I think it's more about the interest and the knowledge rather than the role. So, you know, I'm certainly not going to discount, you know, some of the great other allied health professionals that we work with who equally have the skills to do excellent annual review and follow up and support for people with dementia. So ask the question of your practice and of your PCN, who's your dementia lead? And there will be one. It depends on how active and motivated they are. And I think you can try and hold them to account.
Yes, that's a good response. Not always so visible, I think, is the thing. Would be really interested to hear about how patients with young onset dementia have regular access to a thorough medication review from a clinical pharmacist. I think this has come up before, hasn't it, this question?
Yes. So again, I can talk through what should happen, but I totally appreciate it doesn't happen everywhere. But each surgery should be doing structured medication reviews, particularly for anybody on over more than 5 medications. Again, because it's one of our targets to show good practice in our GP surgeries of what we're doing. Yes, I'm sure some are missed, but they shouldn't be. And it should definitely be, if you hadn't had a structured medication review, again, you could ask. So, you know, you could say, I think I'm due for my medication review. Can we arrange that? And they should respond. They should respond accordingly.
If you were to prompt that, would you how often would you prompt it? Or would you prompt it on a change or over a period of time?
So I think both of those things. It should be annual, but if there's a change, then I would say that would trigger a need or a recommendation that it should be reviewed again. And you know, if new medication is being added in, it should lead and follow on to the next question to say, oh, does that cause a problem with any of the other things I'm taking?
Yeah.
Clinical pharmacists are employed by PCNs, primary care networks. So they have an increasing role definitely in working within GP surgeries. So they're there, they have the experience, and we can ask.
Okay, great. Okay, if I keep going?
Yeah, I'm okay.
When you code the carer, is this under the patient's record or on the carer's own record?
So there's like a reciprocal coding. So the person who has a carer should have a code added as a carer. And then the corresponding person who is the carer should have a code saying is a carer. Yeah, I think that's a really important thing. There's also good things to think about. You know, what does that mean if I'm the carer? And things like, should I carry something in my wallet to say, I'm a carer? You know, if something's happened to me, you need to be aware there's someone who I am responsible for caring for. So, you know, that's a very important thing to add into your carer contingency planning. You know, if I'm unable to be there, someone's relying on me for their care.
Yeah. Is it the case that all GP practices offer annual dementia reviews for those that have a diagnosis regardless of age? And
they should.
I absolutely loved your make it personal, make it count. I mean, of course. Anyway, so is your response they should?
It should. So anybody with a diagnosis of dementia should have an annual review. We know anecdotally the quality of those reviews are very varied, but they should be being done annually, yes.
Thank you. Is there a difference in the progression of young onset compared to later onset?
Sorry, is there a difference? Did you say?
Is there a difference in the progression? Or does it depend on type or?
I hate to generalize because we all know dementia is such an individual illness that seems to present so differently in everybody. As a rule, young onset dementia tends to be rarer subtypes, which tend to progress more rapidly. But you will find exceptions to that rule everywhere.
Yeah. So coming from a non-medical background, question around, well, being surprised there's no regular reassessment of the condition, and asking whether this would help, especially when you bear in mind the new treatments that may emerge over time.
Yes, I think we are definitely in a period of potential big change. You know, if and when disease modifying treatments become more readily available and accessible, I think we're going to have to rethink how we provide early assessment and ongoing review and assessment. So I think that's a topic for another time when we're definitely in a position where those things are available. The question of ongoing follow-up and continuity of care, I totally agree. You know, this is where we need to try and make it as easy as possible for people to come back to us, tell us when things are changing, tell us when things are developing, so that if there are changes possible to improve the situation, we're doing that early rather than waiting for a crisis to come.
Yeah.
Unfortunately, though, I think we don't have the capacity to actively follow up everybody and call them in. You know, certainly there is some, you know, there's a bit of a reliance really on people presenting to us. It's not ideal, but it is unfortunately the case.
Yeah.
I know there are some great organizations with people like Admiral Nurses who are able to do that more proactive follow-up with a smaller caseload. But yes, I think if you don't feel you're getting the follow-up that would be helpful, then you may need to unfortunately be asking for it rather than waiting for someone to contact you.
Okay, thank you. This will be the last question and probably needs to be brief, but it's an important one. How do we reduce the worry or potential fear to share concerns of brain change with GPs? So this is about a person's mum in particular, but those kind of conversations. How do we reduce the fear?
It is not easy, and unfortunately our systems are not set up for making it easy. So I don't think we can put all the blame onto the patient for this at all. I think our systems are not well set up for people to come in when they're nervous or anxious about something. But my main advice would be go with the person that you've got concerns about. Take a list of the concerns you have. If you have a chance to email or send in the information before the appointment, that's helpful sometimes too. It's not easy, but I think try and go with the person and try and put it as clearly as possible what your concerns are.
Thank you.
Yeah.
Thanks very much, Nerida. I need to close it there. You've been brilliant. I knew you would be. Thank you so much. There's loads and loads of encouragement and thanks and chat. We'll share that with you and with everybody attending and those who've registered. We'll be sharing a follow-up email, presentation, the recording, all the links that Nerida's mentioned and that other people have mentioned in the chat as well. And then please do look out for our next Young Dementia Network webinar, which is 19th of November, just confirm. It's on a Tuesday and it's noon till 1, and it's working together to support children and young people affected by parental young onset dementia. So do look out for that and register for it. Thank you very much. Thanks, Nerida.
Thank you.
Thanks.